I bring a combination of excellent technology, my surgical skills, but I go beyond that. I bring the healing aspect into every patient. I bring the aspect of respect for the patient, the ability to understand their unique concerns, and I bring my spirituality into the healing aspect. Patients are not just coming with a brand of a disease on their forehead. They are far beyond that. And what I find unique is that patients are always comfortable with me at the end of the process of the interview, because they realize that my only concern is them, and how to heal them is the focus of the whole consultation process. No two patients are alike. Every person is different. Every person needs to be looked at from a holistic point of view. The word holistic is used in many different senses, but just from the point of view of the surgical scientific perspective, a patient with colon cancer may have other systemic diseases that, unless we take care of them, the outcomes will not be to the level of excellence that I have managed to achieve over the years. Professionalism, as we like to call it, I think the bedside manner can be learned, but if it comes genuinely from your heart and you develop a rapport with the patient, it is so much natural. And it comes from the classic aspect of respecting the patient, as I said, as one of the most important aspects is you respect the patient and you have empathy with the patient, then the rest comes quite naturally. I wanted to be a doctor for a long, long time, and I wanted to become a surgeon since my middle school days. In my middle school, I read a book, Three Brothers Mayo, and that made such a impact on my mind, to the extent that when I finally had my opportunity to come to the United States, I really wanted to get educated in the Mayo Clinic. I get referrals from family physicians, I get referrals from gastroenterologists, I get referrals from urogynecologists, gynecologists, I get referrals from what are called as infertility specialists. I get referrals from medical oncologists, radiation oncologists. I get referrals from general surgeons. I also get referrals from other colon and rectal surgeons. So my practice is very deep. I have become a tertiary care colorectal surgeon, really speaking, because of the unique aspects of my skill sets that have become apparent to the community. So patients come from all different levels. Some patients find me on the internet through web searches for the top doctors in New Jersey. They land on my website, they see the videos that I have posted, there are patient testimonials. So the way patients come to me is quite unique. as a surgeon who takes care of patients with complex colorectal problems such as colon cancer, rectal cancer, inflammatory bowel disease, complex pelvic floor reconstructions, patients who have, let's say, fistulas between the genital and the colorectal organs that have been treated elsewhere, but they have not managed to repair them, then I am the one who is thought of. And so referrals come from various super specialists as well as the primary care physicians in the area, which is quite far and wide actually. A patient that I had operated upon several years ago, who used to live in New Jersey, went to live in North Carolina. Then in North Carolina, he had a surgical mishap from a surgery done for diverticulitis. And then he actually came back here and boarded up in a nearby town and stayed in this area for 6 months for me to solve his problems before he went back to North Carolina. I'm truly blessed by the support that I have from the population as well as the primary care physicians and all the specialists, including the subspecialists that I talked about. There are several aspects of skills that a surgeon needs to have. The first and foremost is to look at the whole person. Again, that's one aspect. And I listen to the patients. So, for example, some patients will come and they introduce themselves, and then they expect that I have read through their chart and I have formulated an opinion. And then I clarify to them that I don't believe that's the right thing to do, because if I were to do that, then I'm doing the same mistake that has often been done, which is why they have not yet healed. You see, they are carrying a brand of a disease on their forehead. I have hemorrhoids, or I have Crohn's disease, or I have this, you see. So the traditional way that a doctor needs to understand a patient and come to a diagnosis is by listening to him. Our skills at history. Some diseases are so simple to diagnose that just listening to the patient for a few minutes, you can come pretty much with nearly 100% certainty as to what disease they may have. Some patients have more complex problems where my physical examination will clarify the diagnosis. And then we can go into the details and the depths about certain special tests that may be needed. So that's one aspect of my skill sets, which I believe is very important and maybe lacking in some of the practitioners of our trade at this point in time, because they are focused on just the patient's chart and what somebody else has done before. You want to understand the person thoroughly. Thereafter, you need to look at, you need to look at the other medical comorbid factors that may impact the decisions that I make. Let's say somebody needs surgery for colon cancer, then it's important for us to also understand what their nutritional status is. Do they have risk factors such as are their lungs going to be able to oxygenate the patient well afterwards? Is their heart going to be able to withstand the stress of the surgery? So Any abdominal surgery, no matter how minimally invasive it is like preparing for a 5K race. If you prepare yourself well, then you can come out winners. At the very least, you minimize the chances of complications happening, and you can achieve outcomes that then can be considered as far better than the competition or what is even reported in the literature. Oftentimes, we need to have a teamwork approach towards a patient care. So, a patient might need a medical oncologist and a radiation oncologist to start with. Especially, this is especially true for rectal cancer. Some of the best outcomes can be achieved by giving the patients chemotherapy and radiation therapy upfront, so that we shrink the rectal cancer, and then my surgical results will lead to the best outcome as far as survival from the rectal cancer is concerned. Patients with inflammatory bowel disease, for example, chronic ulcerative colitis or Crohn's disease, in these patients, oftentimes you have to have a coordination with gastroenterologists who are good at bringing down the severity of the inflammation by using appropriate anti-inflammatory products. Nutritional optimization is often needed for these patients. There are certain patients who come to me, for example, they have rectal prolapse. But if I talk to them and I find that they have, in addition, gynecological organs prolapse, then sometimes a coordination of care is necessary with gynecologists or urogynecologists, so that the whole pelvic floor can be repaired, and that will give us the enduring and high quality options. I give tremendous value to 6 months of the rotation that I did in plastic surgery in my early career as a surgeon in training in India. And plastic surgery gives you the understanding of respect to the tissues. I've talked about respect to the patient. A surgeon needs to respect the tissues. How delicately the tissues are handled gives you the optimal outcomes. I believe that if a patient needs coordination of care, if a patient needs teamwork, then that's what needs to happen. I try to fight for the patient's rights, and really the insurance, I mean, whatever I say would be politically wrong, but it would be helpful for patients to understand that they should also stand up for their rights, and sometimes they need to take these fights to their local elected representatives, and rather than use the doctor's office as the soft target. But I have to tell you that in general, the concept of total care that I have followed has not been questioned to any significant extent. Occasionally there are hurdles, but we have almost always managed to get past them. A classic example, a patient with colon cancer needs a CAT scan. We have to sometimes spend hours on getting approval for the CT scan. Rectal cancer, the patients need CAT scan of the abdomen and pelvis. They need a CT scan of the chest. Oftentimes, they need additional MRI, and that is where our frustration with insurance companies happens, But again, if your focus is on the patient and the patient needs to be seen by a cardiologist so that the surgery can be optimized, then so be it. Surgical skill sets, almost any surgeon can develop, you know. What I have done is I have taken them to another level. I feel totally unique and blessed in that I have now almost a pyramid or a solid base of all the technologies that we have seen in one lifetime. I started off as an open abdominal surgeon. At that time, laparoscopy was not even introduced. There was no concept of minimally invasive surgery. When I came to United States, the laparoscopic surgery for the colon had been done only for about 4 years or so. In 1995, 96, it was almost rejected. It was put under intense scrutiny. And introduction of laparoscopy for colorectal cancer is what led to an explosion in understanding about the evidence-based medicine approach to practicing surgery. And I have done a large amount of original research work in making laparoscopy safe. Today we consider laparoscopy as a given. In surgery, even today, a large number of questions have not been answered in a evidence-based fashion, you see. But when laparoscopy was first introduced, there was so much scrutiny on that technology, and there were so many disbelievers that they then formed a group, and the group was led by Heidi Nelson. The National Institutes of Health conducted one of the largest multi-center trials called as the clinical outcomes of surgical therapy. So it's called as the COST study group, and our center, the Colon and Rectal Clinic of Orlando, had participated in that. And those were the studies that showed that laparoscopy can be done safely for colon cancer. The world's first 5-year survival outcomes came from the clinic that trained me. The world's first 10-year survival statistic from laparoscopic surgery for colon cancer as well as rectal cancer was presented by me in 2002, and it was extraordinarily well received. I have lived this huge phenomenon of minimally invasive surgery, you know, which used the tools laparoscopy from 1991 onwards, you see. And then when I realized that there are deficiencies of that particular tool, like for example, our phones, our telephones have evolved, our televisions have evolved, our computer monitors have evolved, you see. So what happens is that some surgeons remain fixated on that is how we practice and that's how we should keep practicing. So I combine the beauty of the patient-focused care, and at the same time then I bring in the advances in surgical technology and skills that then can make a vast difference. The first time I sat on the robotic console and did some picking up of objects and dropping them in little cups and passing a thread through the eye of a needle, I was so impressed with the dexterity you see, I said I have to now uh, um, learn the robotics field. So once again, 5 years ago, robotics in colorectal surgery was hardly practiced. There were very few surgeons who had done any significant amount of robotic experience. Certainly in this area, I was one of the first to realize its value. I went through a process of extensive self-training. I spent hundreds of hours doing all the modules, and it's like a flight simulator. You see, if a pilot spends a large amount of time and becomes really good at flying a plane and landing it safely on a flight simulator, then you are very likely to do that in real life. Safety in robotics is with safety in surgeons' experience. I believe that my depth of knowledge and understanding of the laparoscopic surgery and open surgery as well has probably allowed me to add to my robotic skills in such a fashion. Over the years, as I started practicing robotics, I haven't looked back. And now, in the last 4 years, I have done close to 300 robotic colon resections. So this is a number, I mean, people, we call something as a learning curve, you see. In surgery, certain operations, like for example, incision and drainage of an abscess. I'm giving a simplest example. You might need to do 2 of them in order to become good at it. It was recognized some time ago that one needs to have 40 laparoscopic cases in order to really overcome the initial mistakes that surgeons can make. In robotics, the learning curve can be shortened if a person does a lot of flight simulator training, but some have come up with nearly 250 as the number, you see. So it is important to recognize from if one is a patient, to ask the surgeon, how many cases have you done, how adept you are at this particular field before they should get into this. There is a much more widespread availability of the robotics all over the state, but it is really important to understand that you want your surgeon to be highly experienced and to have done a vast number of robotic cases so that the best outcomes can then be recognized. There are still some patients who think that the robot will come and hit them somewhere, and and I have to explain to them how the technology works. I remain in complete command throughout. I am the one who is enabled by the robot. If they like me, if they like my hands and my skills, I tell them that, like a Hindu goddess, the robot actually makes me sprout 2 extra arms because I myself can now control 4 instruments. Plus, when the instruments are connected to the robotics system, the instrument tips move with the dexterity of human hand. You see, we have traditionally visualized robot as making moves that are like this, but human hand has these, what we call these as degrees of freedom of movement. The roll, the pitch, and the yaw, these are various movements that make human hands dexterous. And the robotics gives me the dexterity to operate deep in the body. It allows me to see three-dimensional true reality, and I remain in control throughout. We have now almost 95 to 97% ability to complete the surgery using minimally invasive approach when we have all the appropriate instrumentation. So I think in human body, having guarantees to that level or probabilities to that level stacked in the patient's favor is a fantastic development. And when you discuss these aspects with the patients, it is uncommon to find a patient who does not understand these. We still can't give 100% certainties to anybody, but it is not like playing roulette anymore. In my experience, patients have always left feeling a sense of comfort, and they have actually verbalized it. I think because I have nearly several thousand colon resection experience under my wings, I don't have to put on an act. It is natural. I'm a man of science. I have a large base of open abdominal surgeries. I have a huge base of laparoscopic surgery. I have a huge experience of robotic surgery. I have a huge experience of proctological surgeries. These are the hemorrhoids and fissures and fistulas, colonoscopies, and my compassion, my nature, so if you are established in yourself, I think patients sense that. So it's a question of developing a connection. I do not have to put a face. I do not have to act, and we have what is called as qualities of outcomes. You see, it comes from, I guess, just being extremely cautious, careful, and perfectionist, and that comes through. Aside from being a man of science, I'm highly spiritual, so I think that also plays a big role. I do tell the patients that spirituality plays a big role in healing. I will not be a good person if I'm not a healer. I cannot be just operating in a tunnel vision type of a fashion. Just hand skills or technical skills are not going to be important. You have to have the patient comfortable. They have to believe in you. They have to feel comfortable within themselves. I have oftentimes asked patients if they are still anxious, that they may do some breathing exercises. I have told some patients to do meditation, pray. It doesn't matter what their denomination is. I've told them, go to the church, go to the temple, go to the mosque, wherever they wish to go. Go to the soup kitchen. You do some charity work. Do some selfless service. And what that will do, even in the short term, is that they will forget about their own problem rather than ruminating on, oh, I have to have a cancer surgery. Thankfully, cancer surgeries don't have to happen next day. Once the condition is diagnosed, patients sometimes want to have it done the day before, but the ideal outcomes are still achieved when they are fully ready for it. So it helps a lot, and that's the other aspect of preparing yourself for a surgery. As much as you might want to avoid seeing me, everyone should at least come and pay one visit when they are 50. if they do not have any family history of colorectal cancer. Or they can get the screening colonoscopy done from their gastroenterologist. The having high fiber diet, having a good colorectal health lifestyle is very important. And colorectal health lifestyle revolves around high fiber diet, drinking enough water, aerobic exercise 4 or 5 times a day. But it's not going to completely abolish the problems. You know, there are still going to be around. But this is the minimum that one should do. My major hobby is photography, and I enjoy doing landscape photography, and in fact, in my office now, I have several photographs that I have taken, and patients don't even realize that these are the photos that Dr. Patankar has taken. So in one corner, I have a photograph of me holding my Nikon and a lens that a friend had taken for me. So I think if you see the beauty in nature, I guess because I grew up in small towns close to nature, I love nature, and if you like the beauty of nature, to bring the beauty of nature and reveal it through your photograph. And I like to juxtapose the beauty of nature and the scale of nature with the human scale. And we went to the Sand Dunes National Park. The Sand Dunes National Park is in Alamosa in southern Colorado. And I think that was such an incredible experience. These are the biggest sand dunes in United States, and they are juxtaposed with the Sante de Cristo mountain ranges. It was such a fantastic experience, you know, and I have some photographs of the sand dunes where the human figure, which is the juxtaposition that I like to call it, it looks literally like a grain of sand as compared to the scale of the sand dunes. Um, so that's my, you know, I mean, that particular workshop made me so good at it that I actually then made my own website, and it's called as drpatankarphotography.com. And many of my friends and even patients alike love seeing that. Understanding of the pelvic floor physiology has been a relatively new development in the field of colon and rectal surgery. Defecation and ability to hold are two things, two human functions that we take for granted, and nobody really understood exactly how that happened. You see, there is such a complex interplay of factors that allows us to do this. Some of the normal parameters were not even known, like what would be the normal anal sphincter tone was not known, you know. So again, I feel uniquely blessed that this is a highly specialized field within colon and rectal surgery that I was exposed to at an early stage, and I took up the challenge and I did a lot of research. So this is a fascinating field that patients seek me out for. I have a computerized anorectal physiology lab in the office where the appropriate tests can be done in the office setting itself. Again, with complete respect to the patients, and their privacy can be maintained, and we can understand a whole lot more about it. my understanding in this field has been known in a wide area by gynecologists and urogynecologists, because oftentimes the pelvic floor dysfunction manifests not only in the colorectal field but also in the gynecological field, in the urologist's field. And so urologists, urogynecologists, gynecologists, we all work together in helping these patients. The complex pelvic floor reconstruction, as we call it, I have had a significant experience in repairing some of the complex rectovaginal fistulas, anovaginal fistulas, and these are patients who have had failed repairs at other institutes. One of our patients comes from Pittsburgh. The patient had even gone to Mayo Clinic. I really felt a sense of achievement because I have looked at the Mayo Clinic and I was so influenced by the book Three Brothers Mayo that made me want to become a surgeon. But when a patient had gone to Mayo Clinic and then came back to me and a urogynecologist in this area, and so we took care of this patient together, as we have of number of other patients, and we have achieved outstanding results in this particular field. The issue of fecal incontinence, it is quite common, but not much talked about because it's not a good coffee table conversation. Nobody wants to talk about this aspect, you see, but so many patients suffer from this, and there are simple techniques that can help these patients to regain the quality of life that has been lacking, you see. So it's been a fascinating field for me. As much as we know about human body, there is a whole lot that we still don't know. There are aspects of interplay that is especially true for certain chronic diseases. Why people still get, why their own immune system starts acting against their own body is not known. Chronic pain syndromes, we still don't know enough about it. And I mean, I think genetics, there is a tremendous understanding about genetics, but even known genetic mutations, there are what are called as inherited mutations of, for example, familial adenomatous polyposis, where the colon makes hundreds of polyps. But how a inherited mutant gene will have a phenotypic expression in a given patient is so unreliable, you know. So what are the triggers? We don't know. I have a fantastic experience of operating on a 16-year-old young girl. She actually came to me several months before she even turned 16. I got a phone call from a gastroenterologist who was almost sounding panicky. Sanjiv, I have a young girl who I just did a colonoscopy on, and she has hundreds of polyps all over her colon and the rectum. So we did genetic studies on her, and we confirmed that she actually was the index case for this condition called as familial adenomatous polyposis coli. And she needed removal of the whole colon and the rectum. And obviously when you do that in a young person, you want to avoid giving them a permanent stoma or a bag, and you also want to do the surgery in such a way that the cosmetic outcome is also as refined as it can be, you see. So she was one of my earliest cases in my robotic experience. But because I had done a large number of what are called as ilioanal J pouches, I felt comfortable to offer her a robotic total proctocolectomy and ilioanal J pouch as a one-stage procedure. So this is the most extreme operative procedure that a colorectal surgeon is called upon to do. So we remove the entire colon, the entire rectum, we preserve just the anus and the anal sphincters, and then we have to make a new rectum out of the small intestine in order for the person to have some control over their bowel movements. The small intestine is made into a J-shaped, and the two limbs of the J are stapled together, and we make a new rectal reservoir type from the small intestine. And this J pouch is then anastomosed or stapled internally. So she is now 21, and she has grown to be a wonderful young girl who comes for regular surveillance, and it's so the experience that you get takes you to a level of expertise and confidence about yourself that is then easy for other patients to recognize. Nationwide statistics have shown that colorectal cancer has clearly a diminishing trend, and this is definitely as a result of screening colonoscopies that are being done. You see, there are still a large number of patients that are not getting screened, but the trend is clear that as long as the data has been maintained, the number of cases have started coming down. Having said that, there still are about 130,000 Americans that are being diagnosed as new cases of colon cancer and rectal cancer, and that is one too many. When cancer actually develops, colorectal cancer remains one of the best treatable cancer. So we have made advances in many ways. Ultimately, the biology of colon cancer is so unique that is where I think the future lies, understanding the biology. You see, we have genetic studies that can be done on the mutant genes once a patient develops cancer, and we can come up with nomograms that give a personalized risk of recurrence. You see, so depending on the stage of the colon cancer, the risks of recurrence can be predicted. But there are some patients who start off as really small cancers in the wall, but it is metastatic to the lymph nodes already. So that's the biology aspect of it that I think would be the for the future research. There is a magazine on Central Jersey Health that actually did a article on me, and they show me in a yoga pose. So many patients have seen that, and patients think that I learned yoga probably when I was in India. But that is not how it happened. It certainly did not happen that way. I was already a surgeon. I was in United States when I got introduced to yoga. as a doctor, we deplete our positive energies um, uh, that we need to replenish, because when you're talking to a patient, when you are dealing with people who are suffering, who are sick, who are anxious, you are letting your energy flow into them to heal them, kind of, whether it's a process that you fully understand or not. I don't know. I don't fully understand it, but you may feel depleted at the end of the day. I used to suffer from low back pain. I have been through, rigorous surgical training, and I've been all over the world. I spent 4 years in England and did a fellowship of the Royal College of Surgeons, Edinburgh. So the intense amount of work and the desk work and then the kneeling over the patients. So I just went to the Ridgewood Public Library and got a couple of DVDs. And first, when I looked at the DVDs, I was like, if I do that, I think I'm going to come down with a broken back. But what was important was you do what is comfortable to you. So I started doing yoga. It made such an incredible benefit in my own body. My back, I would say, has healed. As far as the your mindset, it makes me so calm. That's one aspect about me that has often been remarked, that I'm always smiling and I'm always calm. And I think as a leader of the whole team in the operating room, the calmness of the surgeon, the confidence of the surgeon, and his spirituality makes a lot of difference, I believe, to the outcomes of the patients. I think the society and your colleagues give back to you what you deserve when you work and achieve outstanding success and outcomes, and you show your compassion, the care for the patients. Your colleagues want to recognize you. So I have been voted again 2016 New Jersey top doctor as well, and they send out ballots to the physicians as to who they would choose as a doctor for their loved ones in case they needed care. So many of my number of my patients are doctors and their families, and so I'm not too surprised that that recognition has come about. And the Physician of the Year award was also interesting. It was based upon the patient's criteria and their satisfaction scores, you see.
The moment I walked in and I went to his office and he stood up and introduced himself, it was just like I felt so comfortable because the kindness in his voice, and he made me feel so at ease, you know. And he talked to me because he had all my records from before. And it started, he set me up for, the surgery. He told me what happened to my large intestines, right? And he was doing a resection. And I'm telling you, he was just wonderful. Not only as a doctor, he's an excellent surgeon, but his bedside manner, I remember younger, the bedside manner was like when the doctor used to come to your house. Yes, that I relate to it, the kindness of him, and he cares so much, and so he's for real, He take his time talking to you, explain everything, and he's so warm. He has such a sweet spirit. He really does, and he's a joy to be around. He really is. Just the way he is. He has a sweet spirit. He loves people. He loves his patients, and he loves the person, who you are. And it's a connection made there, and he make you feel so warm and so trusting. And this is who he is. And every time I see him, I tell him, you know, I love you. I do. And I tell the people about him, you know, because it was so wonderful, you know. I mean, before the surgery, after the surgery, coming and visit him the same way, never rushing, taking his time, you know, caring about you, you see. And how can you not, you know, trust a doctor like that? I never met anyone like him before, you know. I'm 72 years old, but during my years, you know, I never met a doctor just so comfortable and take your time with you and explain and care for you, make you feel like you're the only person at that time, you see. He really is a fantastic doctor. I am so grateful every single day. You know, I get up in the morning, so thank God, because I feel that he did save my life, you know, and he just, I can't explain it all to you, but I'm just so, so grateful. Every year, you know, as I made another year, every day, you know, and I think of him often. And when I talk to people about, you know, having surgery done, because I've talked to many people, you know, I say, well, consider Dr. Patankar, the ones that know me, you know, I said, because he's an excellent doctor and a fantastic person, you know, and he really is. He really is. That's the way I feel about him. I really do. When I came in to see him this time, to, you know, for Corpse Dawn, and I told him, I said, I just love you. And one of the nurses who worked with him, you know, and she came and I told her, I said, I just love that man right there. So she told Dr. Patankar before the procedure was done, and she said, you know, she said she loves you. And I said, I do. I do, because, you know, he's one of the people doing my healing and one of the major part of my care. You know, there was others, but, you know, and I thank them also. I've done the same to them, told them how much I appreciate what they did for me. But Dr. Patankar, I mean, he was just excellent. Yeah, he's excellent, he really is.